are going to now move to the second gap, addressing the gap between clinical trials and implementation into clinical practice and population health. And I'm going to ask the panelists to come and sit. The format today is, for this session is slightly different in that we're going to ask, each of the panelists has a very brief presentation about the project they've been involved in that provides an example of this, and then I will moderate a more detailed discussion. Laura, you're sitting in my seat.
It's very comfy.
I think they're all very comfy. I think I need to bring my water, which is over there. So the first presenter, or the member of the panel is Brett Maricque, who is an assistant professor of genetics and the co-director of our Center for Community Health Partnerships and Research at the ICTS and the Institute for Public Health. And Brett will talk about engaging with underrepresented populations in the understanding of genomics.
Thanks, Bill. Good morning, everyone. So yeah, I'm going to talk about a community-engaged approach that we've been taking to try to increase equity in the world of genomics and precision medicine. So I just want to start by acknowledging that all this work has been developed and done in partnership with Dr. Chelsea Carter, who's currently an assistant professor at the Yale School for Public Health. I got to meet Chelsea when she was still a graduate student here in the anthropology department, and we actually started working on this project together even before she finished her PhD. So when she transitioned to Yale, we've sort of built a research team that is both here at WashU and also in her group at Yale. And our work together it starts here. Hopefully these data aren't new to anyone in the room, but if they are, let me share what this is. This image of the St. Louis region is overlaid with life expectancy data. This comes from the For the Sake of All report, and nothing has changed since 2014. But in 2014, if you looked at the Jeff Vanderloo neighborhood, kind of in a weird place here, but right here, and the township of Clayton right here, there's an 18-year gap in life expectancy between these two zip codes that are just miles apart. And what we know is that if you look at a map of St. Louis in a different way, where here blue is people who are black or African American, and red is people who are white. This sort of diagonal line here, where life expectancy is low north and east and higher south and west, is sort of mirrored by the racial segregation of our region. And so we know that there's a lot of reasons: social determinants of health, access to care, racial segregation, housing, health, wealth, you name it, that are underlying this. And so as a geneticist who was brought back to WashU to address inequities in health, I had to ask the question, how will precision medicine impact this? And I think the way that I looked at it was, well, there are two ways that it could impact this. One is to reduce current health disparities, and the extent to which genetic data are valuable for reducing current health disparities is sort of unknown, and I would argue it's relatively limited. But the other way to look at it is, how do we prevent future health disparities. How do we make sure that the technology that we're developing and the methods we're using are not just like available to everyone, but are acceptable to everyone, and that means bringing people in as sort of co-developers and giving folks an ownership stake in what we're doing, right? And so if we ask, like, what's the current state of genomics and precision medicine, this kind of says it all. This is, by year, the number of individuals globally who've participated in genome-wide association studies. And what we see is that the vast majority of people who've participated in this work are of European descent. So something like 90+% of the people who've had genome sequence or genotype data are white Europeans. And if we look here, like this little purple line is folks of African descent. So Black Americans are just a small sliver of this group of people who've had genomics data, despite being like a relatively large portion of the global population. So we're already behind the 8 ball. We've already missed our opportunity to do this in an equitable fashion. And so the NHGRI in 2020, fall of 2020, put out a strategic vision for improving health through genomics. And part of that strategic vision is a set of guiding principles for how, and values for how to do human genomics. And you'll see, if we draw our attention to this one in particular, there's a big emphasis on inclusion, diversity, inclusion, and access to genomic technologies to make these innovations applicable to the improvement of everyone's health. And so in response to this, and really as Chelsea and I were thinking about our project, we decided to build something a little bit different than what we may be used to. So we developed something called the Black Genome Project. The mission of this work is to understand how genetic research is impacting Black communities here in St. Louis, and also how Black communities value their genomes and genetic data. And we established a few values of our own for our project. These may look like campaign slogans, and surely these words have been used in plenty of campaign slogan, but if you dig a little bit deeper, you'll find that there are scholars, theorists, educators, activists who've written about each of these words, who've developed lines of research and theories about the ways in which these three concepts or words can generate ownership among a group of people who've been disenfranchised, oppressed, left out of the sort of mainstream world. And the way that we've thought about these, it's sort of we can boil these three words down into sort of an approach that we've taken. And the approach is sort of to look at this word "for," the sort of traditional paradigm of an academic institution doing something for a community, and instead thinking about it this way. So we're not doing this for people, we're doing this with people. And for us, what this means in our project is that, and this is no shade at all of us, but we're not planning to send people kits in the mail to deposit their saliva into a genome sequencing database. Instead, we took the approach of sitting with people and exploring the ways in which Black communities in St. Louis have been impacted by genetics and genomics research to this point. And we're hoping to start here rather than start with a genome sequence. And what this means for us is several things. Number one is that we said we have to slow down and back way up. So rather than asking how do we increase the diversity of our genomic databases, we have to ask ourselves, what does precision medicine have to offer? Is more genome sequencing the best approach? How do Black people value their genomes and genetic data? We chose to learn and understand first, and so we set up we chose a set of methods that span ethnography, community-based participatory research, and genomics education to do community-based work. We've completed to this point, our first phase of the project is complete. We did 11 focus groups and 40 interviews with community members, everyday folks from the Black communities in St. Louis. We've collected over 400 survey responses, and we've also humanized a lot of these individuals we've interacted with through photography sessions in their spaces with their families, and so we're planning to put all of those data together to sort of represent what this looks like for everyday people. Along the way, we've built trust and partnership. I'm going to say a little bit more about that in a moment, particularly with an organization called Black Girls Do STEM, where we've integrated middle and high school girls into our research. And this is all with the hopes of fostering agency, cultivating a greater sense of ownership in one's own health. And so I'm not an expert on this word, nobody really is, and I think that's exactly where we want to be. The great thing about the word with is that there's a vast set of people who can provide feedback to you and others about whether you're doing it correctly or not, right? And what I mean by this is we're really centering community members. So I just want to give you a few examples of how we're doing with. By no means are these the only ways to do with, but I think there's some that are working for us. These are some images of our partnership with Black Girls Do STEM. We brought on 14 middle school and high school girls as research interns, and we worked with them for a 12-month period supported by a PDSS award from the ICTS. And this culminated in a trip to Atlanta for the annual Public Health Association's meeting. We actually brought 3 of the students with us to co-present an oral session. While we were there, we visited some colleges, Spelman, Emory. We practiced last minute the morning, of our presentation at the Airbnb. And then these are 3 of the girls, Jariah, Savannah, and Mila, who attended with us. This is a partnership that we're continuing to develop, and it's really a way of grounding us in like, is this something that matters to the community? Everyone who's been part of our project, we've met in person. So all of our recruitment, all of our efforts to get people to enroll in the project, take our survey, that's all been done out in the community. So it's all been, it's all been sort of hand-to-hand combat as we think of it. Like we get out there and we meet people. We don't send Facebook advertisements. We don't spam listservs. We really go out and meet people. This takes place at food shares. This takes place in Fairground Park. This takes place, in Old North at the Taste of North St. Louis, right? So we're really out there meeting people. And this has resulted in us enrolling the people we want to enroll. So if you look at the top 10 zip codes in our survey data, which account for 46% of the survey responses, they're in predominantly Black neighborhoods in North City and North County. And the 2 that aren't, the West End and Forest Park Southeast, are both historically Black communities that have been gentrified by WashU development over the last 50 years. This approach has allowed us to also have fun with our participants. So we play basketball. This is a picture of us doing yoga together at our family appreciation day, which we had last summer, where we brought people in. And fun has actually turned into an additional layer of community involvement in the project, which is something we're calling the BGP, the Black Genome Project Community Education Collective. This is work that's funded by the Precision Health Initiative at the ICTS, and the aim here is to really develop a process for analyzing and interpreting our mixed methods data with community members as co-researchers. So people are going to learn how to analyze data, gain specific quantitative, qualitative skills. They're going to contribute their unique perspectives to the interpretation of our results, and we're going to co-create visual representations of the data that hopefully will end up out in the community somewhere. We have our eyes on maybe a museum exhibition in a year from now or something like that. And like I said, we're doing this together. This is some pictures from our first session where, you know, Chelsea and I are here, but it's really, the action is actually down at this end of the table where people are starting to discuss the data that has been collected from the communities that they represent. And so I wanted to end here, and I guess we'll take questions later or now?
3 presentations first. So keep your specific questions as well as your general questions and from the 3 presentations, and we'll move to the second one, which will be given by Laura Marks from the assistant professor in the Division of Infectious Diseases, and her title is, I think, self-explanatory.
Thanks for having me this morning. So I wanted to tell a story about how we can span some of these gaps in caring for populations that sometimes aren't included well in clinical trials research and can be more vulnerable. And for the population that I work with, this is people who inject drugs. So it's not a surprise to many in this room that there are a lot of complications that can come with injecting drugs. One of the complications we see most frequently in the infectious diseases division is really severe invasive infections. Infections of the heart or the joints or the bones or the spinal cord. And these kill our patients. Without intervention, these are incredibly morbid infections with a really high mortality rate. And so the questions that as a junior faculty member and even as a fellow I was interested are kind of basic questions. And if you don't put the context of the population that I'm interested in, you would say they're a no-brainer. Things like, should we give antibiotics for a infection that in the pre-antibiotic era had an incredibly high mortality? Should we make sure that we don't reuse syringes from a person that has an infection to a person that doesn't? Like, if I asked that of my division chief and I didn't give some context, hopefully he would, you know, be mildly horrified. But sometimes it's hard to take that information that we take for granted and move from a population it was studied in to another population. And this is where I think that sometimes asking the silly questions and using basic science can help us remember that common sense works for a reason. And so when trying to improve care for this population, we really started by trying to listen to them again. And I was really lucky to work with a fellow at the time that was really interested in narrative medicine and the experience of people when they came to the hospital and they had these infections. And we worked on a set of qualitative interviews, just asking our patients that showed up with these infections how they thought they got them and what their experience had been before they came to the hospital. And, you know, none of the things that we discovered are huge surprises, but there are a couple of really important themes that come to light, that in Missouri, there's not a lot of access to sterile supplies, that many of our patients who use drugs have really low health literacy, and that they've had bad experiences with the healthcare system before, and so they've avoided them. And sometimes that has led to the problem compounding itself. And without explanation, they might not make that connection of the fact that I inject drugs in my arm and I'm being treated for an infection in my spine. And, you know, to us as infectious diseases specialists, of course that makes sense. But if you don't explain it to the patient, sometimes that information doesn't really click. And so I was trained as a basic science researcher, and I wanted to try to find a way to bring that back into my practice. And so we started thinking about trying to prove some really basic stuff. Where do these infections come from? But also to recognize that for our patients, these infections exist as part of a larger disease process. They're part of their substance use disorder, and trying to put that hypothesis within a syndemic framework. And we call these overlapping epidemics that have been happening right now, you know, the epidemic of overdoses, of stimulant use, of the opioid crisis, along with epidemic of infective endocarditis or viral hepatitis. We call this a syndemic. And so we wanted to think about where these infections were coming from within that syndemic framework. And so we thought about how our patients use drugs, that they don't have access to sterile supplies, that they don't have access to a lot of hygiene equipment often. And we tried to track down where our patients that had the most common infection, Staph aureus, were getting their infections from. So we involved our patients in the hospital in a prospective biospecimen repository collection where we said, talk to us about how you use your drugs. Fill out a survey for us, and then we would love to swab your skin. We would love for you to swab your drugs, and then we're gonna get your bloodstream isolates. And we wanna know what matches up. And I think the first thing that we learned is that our patients cared. Our patients cared about their health. They cared about where these infections came from. They knew the drug supply was contaminated, but no one had ever talked to them about it being contaminated with bacteria. They just knew what they heard on the news, that it was contaminated with fentanyl. And so we found out that yes, they are colonized with staph, just like all of us in this room is, but that for our people who inject drugs, maybe that wasn't enough. So some of them were colonized with what they got an infection from, but not everyone. So where did those other ones come from? And we had really, a lot of people were able to take home these home kits to swab their own drugs. Not everybody returned them. Our patients' lives, if they're struggling with a substance use disorder, are chaotic. But those that did were really enthusiastic about it and saying, I want to know what's in my drugs. I want to know where my infection came from. And then we were able to sequence those isolates. But because we didn't get everything back, one of the things that I think was most exciting of this research is that we were able to partner with an organization that the Institute for Public Health has helped fund some of their outreach, which is Street Med STL, and it does really amazing wound care for unhoused populations who use drugs and goes out into the community and delivers harm reduction supplies, helps take care of complex wounds. It's a group of physicians and nurses that go out and do it on the regular. And they helped engage this exact community that we were interested in and say, we're gonna look at what's happening within your drug supply and bring that back into the lab and then culture it and sequence it and spend it over the mass spec and do all the things and find out what's in the drug supply. And this won't come as a huge surprise to anyone in the room, but sometimes the really basic things in life are worth stating, which is that street drugs don't come with an ingredient list. They're not sterile. The meth that gets made, locally, it's not cooked up in a good manufacturing processing facility where someone's wearing a bodysuit. There's bacteria in it. There are other things in the street drug supply. And it's really important for our patients to understand where their infection comes from if they're gonna make sure that it doesn't happen again. So this is my mock label. But yes, our drugs have fentanyl, but they also come with a side of staph and a side of bacillus bacteria and all sorts of other fun additives that you won't find on the label. And these additives are making our patients sick. The staph isolates that we see in the drug supply, those are the same ones that we find in our patients' bloodstreams. And I've been really fortunate to partner with amazing basic science labs, and most of this work is done by Drew Schwartz and his lab and his technicians to try to map this out and see where do those isolates in the drug supply wind up in our patients. Is it in our hospitalized controls? No, it's in our patients that are coming from these unhoused communities that are using drugs that are winding up with lethal infections. And so then you can ask that same really, really basic question and ask people, how do you use drugs? And so we asked a lot of people how you use drugs. We took those qualitative interviews that we did, and we asked specific questions. Do you wash your hands? Do you reuse needles? Do you reuse syringes? Do you drain an abscess and then use that syringe to inject your new drugs? And the answer is yes, because they don't have access to clean supplies. And yet, sometimes as physicians, we make things harder for ourselves than we need to be. So when we asked our physicians on a national survey, how do you counsel your patients? The majority of them said, or almost half of them said, well, I don't feel comfortable counseling. I don't have the knowledge to do that safely. But the knowledge that you need sometimes is just really basic to say, washing your hands is good. We teach, infection prevention about making sure that medications are administered safely in the hospital. It's basic hat for us to say washing hands is a good idea, cleaning sites before we put in IVs is a good idea, not reusing needles is a good idea, and that's all the education that our patients need. They don't need specific information on preparing fentanyl. They're really good at that. They need information on the fact that your infection came because washing your hands is critical, because bacteria can live on your syringe over time. And so we have tried to apply that information, and sometimes using some basic science to relearn things that we already knew, like hand hygiene is important and sterile supplies are important, is really, really fundamental. You can take that a step further and say public health interventions that support access to safe supplies are really important too, because syringe services not only help reduce the rates of HIV, they help get contaminated syringes that are covered in bacteria off the street. You know, they help make sure that these syringes aren't reused over and over and over again because people have access to safe supplies. Because when you're injecting drugs, an infection can come from anywhere along that continuum. So I really love this quote from one of our patients that I think really summarizes this and says, you know, if we're gonna do this, help us make it safer. You know, this is a disease. You know, we treat the substance use disorder, but it can take people a while to quit, and it can take them many tries. Just like if you're trying to quit smoking. If you're trying to quit opioids, it's hard. If you're trying to quit stimulants, it's hard. And in the meantime, having that really basic information to connect the idea that my infection in my spine came from the bacteria on my skin or it came from a contaminated needle is really important. So the very last part of this talk, which you know, I'm going to connect back to the clinical, is that sometimes in medicine we get really caught up with guidelines. We get really caught up with what is the gold standard. And sometimes we have to remember that our patients want to be healthy, but sometimes they're not going to want that gold standard. It doesn't work for their lives. And so in that case, we have to make sure that we don't let perfection be the enemy of really good clinical care for people. So this was a study that we did with our team, which asked a really, really basic question. If your patient that has a fatal infection is leaving the hospital, is it better to give them no antibiotics or to give them an antibiotic that maybe isn't exactly the gold standard, but it's something? And it turns out that giving them an antibiotic and continuing to gauge them in clinical care, even if it's an oral antibiotic and you would have loved to give IV, is still better than giving nothing for a fatal infection. And this may sound like a really, really self-evident thing, but we used to do this a lot. We used to say, if you're leaving against medical advice and you don't want the gold standard, there's not a lot I can do for you. And it turns out that maybe that's not right, and maybe we can apply information we know from clinical trials outside of the audience that they were initially fitted on. And you know, we talk a lot about the gap from taking information and putting it into practice, but I was really excited that this did not have a long gap, and I got to be part of a guideline panel that wrote the American Heart Association scientific statement on infective endocarditis and people who use drugs, where, you know, the top two headlines in our statement were, please give people harm reduction education so they don't get another infection, and if they're leaving the hospital with a fatal infection, please give them some antibiotics. Because, you know, sometimes it's okay to ask a stupid question, and to make sure that we talk about their underlying substance use disorder, because it is the form of source control for this patient population. So with that, I'm just going to put up my little model here, because we can think about this from a basic science lens of where these infections come from, but we can also add in the really easy interventions. I won't say easy, but the interventions that we already know work, that we've studied in other populations, that we can apply to this one and say, hey, if we know where the infections come from and we know how to prevent them, then let's think about using those to interrupt this disease process. Let's think about safe supply. Let's think about multidisciplinary care plans for patients that have infections from complex disease processes. Let's think about substance use disorder care, and, you know, let's think about hand washing and making sure that we don't reuse things. And this is our clinical team. I've been really lucky to partner with amazing basic science researchers and really outstanding organizations that go out into the community. So Nathan Nolan runs Street Med STL, that did a lot of the work that was funded by IPH for talking with patients and collecting specimens, and then Drew Schwartz and Jeff Henderson have partnered on the basic science side to lead some of the genomic stuff and the mass spectrometry work.
We will now have another presentation on another aspect of this, as you can see, a title, De-implementation of Low-Value Care, by Nandini Raghuraman, who's Assistant Professor of Obstetrics and Gynecology.
Thanks, Bill. Good morning, everyone. Like Bill mentioned, I'm Nandini Raghuraman. I'm a maternal fetal medicine physician, and my main area of interest is obstetric clinical trials. And I'm going to tell you a little bit more about my personal voyage into de-implementation and how I moved, still do trials, but sort of moved more into the de-implementation side after learning a little bit more about the work that needs to be done in the world of OBGYN. So I'll start with a summary of sort of what motivates me and many others in the world of OBGYN to do this kind of research. And it's because we are far behind many other fields in terms of having evidence-based guidelines. And I know Bill mentioned earlier sort of the movement of how long it takes for evidence to move into practice. In obstetrics, we have a little bit of the opposite problem, where because we're so deprived for evidence, the second that there is a study that demonstrates something, we immediately move it into practice. So we actually have the opposite issue, and that's perhaps why we struggle more on the de-implementation side of things. So I'll walk you guys through that in just a second. But just for some background, we have over 3 million deliveries in the United States, and of that, about a third result in major abdominal surgery via C-section. And despite our best attempts at managing labor and as much evidence as we have in the year 2024, about 250,000 babies that are born full term are still at risk for morbidity and ending up in the neonatal ICU. The average new mom in the United States pays about $4,500 out of pocket, despite having private insurance, for their labor and delivery care. And so it really just highlights the need for cost-effective care, but perhaps we need to start on the effective side first when it comes to obstetrics. The other important piece I like to highlight is that only about 1 in 15 recommendations from national OBGYN societies are based on randomized clinical trials. So if we sort of look at the traditional perspective of moving from bench to bedside, we used to, I think that it was like a nice straight arrow, but clearly, as we talked about so far this morning, it is not a nice, clean, straightforward arrow. And this diagram is just representative of all the things to account for in the sphere of moving things from evidence into clinical practice, and the same concepts apply for de-implementation. So if we think about, of course, at the patient level, things like patients' acceptance of the data, their awareness of the data, and perhaps how they may be influenced by peers and social media, et cetera. This is especially relevant in the birth space. The second is the provider. So one thing that I have learned through this work is that obstetricians, clinicians in general, are very wed to the way in which they have trained and the way in which they have learned practices sort of growing up in the world of medicine, and it becomes really hard to separate what they've learned from real world evidence. And then certainly at an organization level, things that sort of factor into that are the culture of a particular unit, or a hospital system, for example, what the staffing ratio might be like to execute a particular intervention, et cetera. And then lastly, policy is the other thing that sort of speaks to influences on clinical decision making. This is especially relevant to national guidelines and national societies. So what is de-implementation? It is essentially the process of abandoning or reducing the use of medical practices that are low value. So essentially that are ineffective or harmful. And that's about 30% of interventions across healthcare. Many of you might be familiar with the Choosing Wisely campaign that was launched by the American Board of Internal Medicine, which essentially highlights low-value practices within various fields of medicine to sort of minimize the use of those interventions. So I'm not going to go into sort of the process of doing de-implementation work, because honestly that could be a whole talk in and of itself, but I wanted to highlight that it's not as straightforward as telling people to stop doing something, right? Like that is the important thing that I want folks to take away from this, and I'm going to give you my own personal example, but there is really a methodologic approach to de-implementing ineffective interventions. So my story in this relates to an age-old practice on labor and delivery. When I was a resident, it was very common practice to give moms in labor an oxygen face mask if we had concerns about the fetal heart rate tracing. And I'll explain some of the biology for why we did that in just a second. But this, again, I put this triangle on this slide to really highlight that I used to very naively think that in order to change this practice, that we could just nicely slide across this triangle, start with research, synthesize the research, publish that research, move into guidelines, and then we will beautifully change practice, right? But that it's clearly not as straightforward as I thought. So up until very recently, maternal oxygen supplementation was given to at least 50% of laboring patients. And the thought there was that we monitor the baby's heart rate during labor to identify babies that may be in distress from not getting enough oxygen or hypoxia. And if the baby is hypoxic, as demonstrated on the heart rate tracing, then perhaps giving mom extra oxygen can help fix the baby's hypoxia and prevent that transition from hypoxia to acidemia. So this really was the practice for decades in obstetrics, and it came out of, well, some theoretic rationale, but also because there were animal studies in the 60s and 70s that show that maybe it could make a difference, and some smaller studies in about 10 to 20 patients that look like maybe oxygen is improving the baby's heart rate tracing. And this was actually recommended by ACOG, which is our governing kind of OBGYN society, for years as a way to manage concerning fetal heart rate tracings. We call those category 2 tracings. But if you really delve into it, and I was a resident, and I thought a little bit more about the sort of biology and science of whether this is helpful or not, and for most people, this hemoglobin dissociation curve is pretty painful to even think about again. But if we delve into the science a little bit, most people who have normal oxygen saturations are hanging out in this area of the curve where the red box is. So increasing mom's PO2 is unlikely to change how much how much oxygen is really being transported to the placenta and how much is being unloaded at the level of the placenta. So biologically, it didn't make much sense that this intervention would be helpful. And then over time, there became more and more growing evidence for why we should readdress this practice. So one was that there is definitely evidence outside of obstetrics, so in pediatric literature and adult ICU literature, that over-oxygenation is harmful. And second, we learned through the pandemic that although oxygen isn't costly, it's a very precious resource. And we definitely had places throughout the world where oxygen was not even available when it was needed. And then lastly, a lot of the work that we and others have done in OBGYN have demonstrated over time that this practice of giving moms oxygen was really not effective for improving the baby's heart rate. This is one of the first randomized trials that we did on our L&D unit here, comparing oxygen to room air in patients that were laboring, and found no difference in the baby's cord gases, which are meant to sort of represent the baby's oxygenation status. And they were essentially equivalent, and then we also followed that by doing a meta-analysis of several other studies that have looked at similar interventions, and again found no difference or benefit to the baby by giving oxygen. So ultimately, we were really happy when in 2022 ACOG changed their guidelines based on a lot of the evidence that our group and many others generated, and they changed their guidelines to now recommend against this practice, which is every trialist's dream come true, right? You do a trial and it changes guidelines, but little did I know that this was actually the start of where a lot of my hard work began, and it was just the start of our journey in this space. So did the guidelines work? The short answer is no. So since then, we've done a couple of surveys to look at how whether people are following the guidelines, and we surveyed labor and delivery staff, including nurses, technicians, midwives, et cetera, throughout the country, and a little under half continue to use oxygen. And we also sort of looked a little bit more into reasons and motivations why, and I will tell you that it varies widely across the board, from being from as simple as like I was told to use it to I truly believe it works, and I want to keep using it. And then the other complicating factor after that was that although the OBGYN Society recommended against its use, the nursing organization for obstetrics recommended continued use. So that also left us in a little bit of a challenging spot in terms of moving evidence into practice. So that is what inspired that the sort of continued equipoise in this space is what inspired our current multi-center trial, looking at sort of more clinical measures of neonatal morbidity, which is what the nursing organization really wanted. So stay tuned for those results. But I wanted to also highlight, the work that I'm doing in oxygen is really still in that gap of actually moving into de-implementation. The next step is really doing the science of de-implementation. So I wanted to highlight some amazing work that's being done in this space in pediatric infectious disease. This is the operatic trial led by Jason Newland and Ginger McKay here, and they have looked at de-implementation of unnecessary post-op surgical antibiotic prophylaxis, and they are doing a multi-center step wedge cluster trial and studying 2 de-implementation strategies related to order sets and facilitation workshops to sort of get folks to stop using unnecessary antibiotics. So I'll end with this quote from John Maynard Keynes, who was an economist during the Great Depression, and I thought this quote really summarizes the work that we need to do in de-implementation, which is the difficulty lies not so much in developing new ideas as in escaping from old ones, which I think plagues a lot of our fields of medicine. So thank you.
Before we go into sort of looking at this in general, and your thoughts about the general issues, I wanted to see if the audience had any specific questions for any of the presenters about some of the material that they presented. Okay, if not, let me start by asking a few questions. So one of the things that is really characteristic of all 3 is that the medical community across the board often gets stuck in ways that become they're anachronistic, but they're actually they're established because this is the way I've always done it, or this is the way the guidelines are, or it's too much effort to do something different. And I'm just wondering how you've approached the notion of really changing that paradigm, because sometimes it can be really difficult. We talk about patients being difficult, but actually often the challenges our colleagues are unwilling to change, or to change their perspective. And so I'll start with you, because you've actually tried to do this in a very systematic way, but I think the others will also, I'm interested in your other perspectives as well.
Yeah, it's tough. I could probably devote my whole career to sort of eliminating, working on the physician side of this, honestly. So I think that what I've learned is that the first important step is sort of understanding why people are so wed to their beliefs about a certain practice, despite being shown evidence otherwise. So I think we're all trained to understand evidence-based medicine, and for the most part, we really want our students to graduate feeling like they can pick up a paper, read it, and interpret it. But I've learned that alone is not enough, and that there are some sort of cultural aspects of an intervention that might play into. So I learned, for example, through oxygen, that folks are worried about being sued, medical legal. If I don't give oxygen, will I get sued? So there are some other factors that sort of play into why someone may choose or not choose to use an intervention. So I think figuring that out is an important step. And then Honestly, I think an important strategy that works is eliminating the option entirely. So one of the most successful de-implementation strategies in obstetrics, for a recent story I'll give you guys, is that we used to prescribe progesterone widely to prevent preterm birth, but now there's a growing mountain of evidence that that's no longer helpful. And there was still a mix of practice, but when it got taken off the market and it was no longer an option, we de-implemented that practice. So I think that so perhaps in some scenarios, the best strategy is to just eliminate the option. But there are other strategies to consider when it's still an option.
I'll add on to that. I think the medical legal aspect can be really huge. It's scary taking care of someone and doing something new for the first time if you're doing something outside of what your colleagues do. And so sometimes I think it's okay for change to start really small and to, show that we're going to try this in a couple of people. Maybe this is a guideline. Maybe this is something that's been suggested at another institution. But here we're going to start small, and we're going to start taking care of a few patients this way. And the thing that really helps the most in my experience is to find someone to champion it and to own those patients and to own that practice. So when we started, doing things like making sure that our patients that left against medical advice all had antibiotics, sure, now that kind of sounds like a no-brainer, but at the time, it was a little bit scary. Like, this is outside of what most people do. And so having a team that was willing to accept ownership of those patients from the moment that they started thinking about leaving and the moment that they left the hospital and take ownership of them in clinic and be the attending of record, really, I think, at least for us, helped make that a department practice that, yes, this is what we do. Yes, we have someone that cares. Yes, someone's going to take ownership. And I think that that's applicable to a lot of settings, is that, clinical champions locally and regionally and at a national level can really make a huge difference for helping either de-implement guidelines or implement new ones. Yeah.
I think it's on, but...
Now it's on, yeah. One additional thing that I would say is, like, there's a historical context that we have to address, which I'm sure most of us are aware of, that there's a long list of medical mistreatment, abuse, neglect that has driven some of the mistrust that you mentioned earlier, Bill, and so we're sort of already in a hole as a biomedical institution. And then the data I showed earlier, specifically in the genomics field, where we've ended up with databases that are 90+% white Europeans, like that didn't happen by accident, right? That happened by design. And whether it was an explicitly racist approach or whether it was racist due to the structural factors that exist in our institutions, like that, we can debate that. But the fact is, like, we've dug ourselves in an even deeper hole. And if you go to the NCAT's website and look at this, there's like 6 areas where they're doing work. Within each of the descriptions of those 6 areas, 5 out of the 6 descriptions of those areas include a reference to speed, acceleration, doing things faster. And so I think, like, one thing we have to check ourselves on is, like, and this includes, like, the funding agency who's driving the community engaged work that we care about, is like, speed is probably not the answer. Like, speed will probably dig us deeper. It probably will not help us climb out of the sort of hole we're already in. And so, like, I think the things we're doing are going to take time, and they're going to take efforts from investigators that are well partnered within their fields, that are partnered across fields, and that are also partnered with the communities that they are trying to impact. And all of those things take time. So yeah, I think it's just we need support for that. Like, in order to allow for that time, like, we need support, like, at the institutional level, but also at the external level.
So let's explore that a little bit more, because all of you have really talked about areas where the current data, where we are now, actually has created a problem. So it's whether it's clinical guidelines that are actually based on poor data to start with, or data that was collected that are driving approaches that excluded specific populations, or clinical guidelines that, based on clinical trials that were actually very well done clinical trials, gathered the evidence but didn't include the population that you were faced with in a changing clinical time. And I just point out that the substance use disorder issue is really recent. When people think about it, yes, we've had problems with opioids and injection drugs for many, many years, but the epidemic proportion is really in the last 7 years or 8 years. And so when people did really good trials for endocarditis, there were very few people who had drug use in those populations. So from a thinking it is not for your individual population, but are there generic approaches that we should be taking? Are there ways we should be thinking about this, either to address the evidence gap or to improve the way we gather this? And Brett has talked about, obviously you need time to do this, and if you're building trust, you actually have to do that first. But thinking of it more broadly from an institutional level, what would you think we need to start focusing on?
I think one of the things that I've seen a movement towards recently that I think is really intriguing and key is this concept of living guidelines. There have been a couple of times where this has been implemented in the infectious diseases literature, where guidelines, are updated more frequently, and it's not one guideline that stays there for the next 10 to 15 years, because as you pointed out, our substance use disorder epidemic is recent. And, COVID is recent, and all sorts of things are recent, and, the practice of medicine is constantly changing, and guidelines have to reflect that. So both at a broader, national level, as well as, the concept of what is our divisional standard of care, what is our institutional standard of care. So the thing that I've loved most recently is the introduction of some of the new living guidelines.
Yeah, I think I would just echo what my co-panelists have said already, but the only addition I have is that for those of you considering kind of human subjects-based work, is to be as much as generalizable as you possibly can, because I think that also is what allows us to move that into the clinical space. I'll tell you from having a seat at the table for some of the generation of national guidelines that the majority of excuses that are made to not implement some evidence and to be choosy about which evidence we choose to follow is when folks are excluded from trials. So like, oh, this subgroup wasn't studied and that subgroup wasn't studied and this isn't generalizable to my population. And so that is where we tend to lose or fall in the gap the most. So I'd say if you could include as many of different types of patients as you can in your work, that is more likely to help. I'm gonna give a shout out to Dr. Lenz because he's here, and he's a great example of someone who has done this recently of most clinical trials that have sort of excluded pregnant people outside of the world of OBGYN, and he designed a beautiful trial during COVID that included pregnant patients and allowed us to sort of extrapolate that data over to the world of obstetrics. So I think that if we modeled more work similar to that, not just with pregnant people, but across the board, many different subgroups, that we're more likely to have usable data.
I don't take care of a lot of Goldilocks patients in clinic, and I think most of us don't.
So this raises a really important issue for where we are in our healthcare system, and also at this institution, is that we actually generate a huge amount of data on patients. We have electronic medical records. And people talk about the concept of a learning healthcare system. So I want you to give me your initial reflections on how we could better use the fact that we actually are generating lots of information, and how we can use that, and what are the risks and pitfalls that you might see if we start to create a system whereby we have a learning environment and we give ourselves, and we're capable of actually using it to feedback. Start with that, Brett?
I mean, I would, one place to start would be a fear, which is, or a concern, which is that a piece of data, like a piece of data in an EHR may easily be mistaken as a piece of biological data, which it may be, but it may not be caused by a genetic variant in that patient. It may not be caused by a biology that is different in that patient than in another patient, you know, systemically. It may be caused by a social determinant of health. And so one fear that I have is that the more we sort of rely on EHRs and the more we sort of connect EHR data to genetic data, we lose sight of the fact that when we're talking about diverse populations, when we're talking about populations in our city that face vast differences in material conditions and lived environments, that we don't consider the fact that some of these things we're measuring may be caused by social factors and not things that we can change with gene therapies or biologicals.
So when I'm on clinical service, sometimes I hate our EHR because there's a lot of clicky buttons and I get a little bit annoyed about it. But I think that, you know, one of the really brilliant aspects of it is there have been some trials and studies at other institutions which have really leveraged the EHR for good and have leveraged it to include people in trials. There was a really big trial looking at Piptazo versus cefepime for patients who were critically ill in the ICU, and they used the EHR to help enroll a really diverse sample of people. And we were inspired by that, and we've tried to leverage our EHR here to help, you know, enroll patients and put in best practice advisories, but also use the EHR for simple interventions like expanding things like HIV testing in people who use drugs. So I think one of the really cool things about the vast amount of data that our university turns out and the EHR collects is that, yeah, some of it can be used for evil if you're not really careful about how it's done. But it also has a really huge reach. You know, it reaches across the health system, and if you're thoughtful about the way that you implement things, it can really be used to help bring guideline concordant care to many, many different patients that you might not actually have an opportunity to meet in person. And that's my rambling response.
Thoughts about how we could use the EHR better to de-implement as well as implement?
Yeah, it's actually one of the tools in a de-implementation strategy. So, you know, I mentioned Jason Nolan and Ginger McKay's work. They're actually using EHR to their benefit to kind of change order sets in EPIC to get folks to de-implement the use of antibiotics. So it takes an extra step to go in and order an antibiotic. So a little bit add that added barrier. It makes folks less likely to do it. So I think EHR can really be utilized in that way. It can also be used for sort of audit and feedback strategies to say, you know, like, hey, your peers have used oxygen 10% of the time, you happen to be using it 75% of the time, and then to use that as a way to sort of study why they're high-end and lower-end users of a particular intervention.
So again, I want to make sure that we have an opportunity for the audience to participate. So are any questions, comments from anybody? We have one here in the middle.
I have a love-hate relationship with electronic health records. I find them very, very useful to probe existing knowledge being the data in the set, to pose future questions. I find them very, very frustrating when people tell me, oh, just go look at the records. Because the records are what someone entered when they were sitting and they were a very, very busy person, probably trying to get the next person in the office or trying to interpret clinical notes from someone who jotted them down very, very quickly from like a qualitative researcher stance. That's your first guide for the next question you want to ask as you go in and actually listen to the person. And I think that's often a divide we get in healthcare, finding the answer quickly versus listening to people. And that includes both the professionals trying to deliver the care, because rightly or wrongly, I believe that clinicians want to help the person who's in front of them. And from the patient's perspective, that we don't understand that they actually want to be healthy.
Any other comments? Eric?
I hope I don't get in trouble for this question. We're seeing emails about a pending greater partnership between the School of Medicine and the entire BJC system. Do we think that there will be big opportunities to convert, as it were, BJC into a learning health system?
I think that's a wonderful question. I'd be very curious as to, given the practical experience of the panelists, to think what they would see as the potential of expanding what we're doing beyond just this physical location. And then I hope others in the audience might want to reflect and comment on this as well. It's a critical issue in where we are in the evolution of this organization.
Oh, I thought that one was for you.
It is for me. I'm going to answer it later, though.
I can't say I have an insightful answer to that, but I will comment that I often think that the existing sort of bridge between BJH and WashU sometimes is what makes it challenging to sort of involve all stakeholders when we're addressing a question or an intervention, right? So especially if I use labor and delivery an example, the nurses there belong to the BJH entity, the physician side belongs to the WashU entity, and so getting all of those stakeholders at the same table becomes challenging. And so I think my hope is that this union will, or continued union, I should say, revised, updated union, refreshed union will sort of allow for more ease in bringing all those stakeholders together.
From a very practical standpoint, I'm excited about it because a lot of our patients' care isn't, a one-stop shop in the hospital. It's a continuum of care between the inpatient and the outpatient side, and sometimes it can be really challenging to try to navigate the fact that sometimes we start interventions with a multidisciplinary crew, inpatient and BJH, but we want to make sure the patients still have access to those same resources on an outpatient side, or we want to make sure that, interventions placed in one area flow well between it. So I'm excited about a greater intervention from just that inpatient-outpatient connection.
And I'll just make a comment based on something that Bill said about we work inside of a healthcare system where cost and the ability to actually get things happen, there has to be an incentive, and cost could be one of those. I guess I just wondered more broadly, what other incentives are there in the system that you play off of to try to make things happen?
Cost, readmission, people not wanting to be to own it. They're really happy to have someone to take care of challenging patients, and sometimes it's okay to play off of that, especially if you're junior faculty. I don't know.
I think patient outcomes, honestly. So if for example, when I'm trying to get nurses and the obstetricians to be on the same page, presenting data related to patient outcomes seems to be an important motivator outside of cost. In fact, cost, for some reason, is less of a motivator for our providers. And then I think the other thing, because we've done some work to sort of study why pregnant people do and don't want to participate in research, and interestingly, majority want to participate, because of altruism. Like, they want to help other people, and I think that is another important motivator to highlight as well.
Dr. Klein. Sorry.
Thank you. I wonder if you could comment, and this is for Bill and anyone else as well, on including the minority populations in population health as well as in clinical trials, and particularly one that's growing but we don't seem to have such a good connection with, which is Latino Hispanic population.
So I do think I will comment on a couple of things, but I'll come back to the panelists specifically about disadvantaged populations, because I think. But in terms of Eric's question and the opportunity, what I would say is that as we expand the affiliation agreement from the perspective of clinical and translational research, I would start by making a couple of observations. The first is that, and we all work at an academic medical center, but less than 0.5% of Americans receive their health care at an academic medical center. So to make what we do relevant actually does mean that we have to make it relevant not only to what happens at Barnes Jewish Hospital, but what happens right across the community. The second thing that COVID showed us was that at a time of crisis, in the academic healthcare systems didn't look after the patients who needed the most help, the disadvantaged, the poor, and people of color. And that if we have an opportunity to expand what we do in terms of clinical research into those populations by virtue of expanding our capability of working more closely with a system whereby many of those patients receive their care within the system but not necessarily at this site in the system, then that's an opportunity, and failure to grasp that opportunity would be a failure. So for clinical researchers and would-be clinical researchers and the upcoming generation of clinical research, I think this is a great opportunity. It does require thought and investment. It does require working with those communities, and not just for example, if you were to think about working more closely with Christian Hospital, it not only means working more closely with the African American population that is served largely by Christian Hospital, but also working very closely with the providers who are currently there to understand and educate them about the value of clinical research and the potential value of them participating and having the patients they care for participate in clinical research, but also providing them with resources, not just adding this to their workload, which is already considerable. And I think this is where, as a medical school and as an institution, we need to think about how we would do this. I would want to make one other comment that I think Brett's comment about the electronic health record is important for all the audience to think about. He mentioned the fact that the social determinants of health are often not really properly captured and therefore available. But the other thing that we often forget is that, but has been well shown in studies, is that the electronic health record captures what current practice is. And unfortunately, there may be both true and unconscious bias that actually affects how different populations receive their care. Laura gave a great example, not based on race and ethnicity, but based on a condition whereby patients who were challenging, drug users, received different care by virtue of the fact they had an underlying condition. But we know from data from other institutions that underserved populations not only may receive less care, but they also may receive different care based on often unstructured bias by the physicians and providers who are caring for them. So it's very important that we think about this going forward and think about how we would overcome that. And to Dr. Klein's question, I mean, I think that's one of the values that the emphasis that our ICTS has put on community engagement and our Center for Community Health partnerships and research is that we have really put a huge amount of thought into and have great leadership in terms of how we engage with our community to make our research not only relevant to the community, but also ultimately of benefit to the community. And I think that's something that we would strongly encourage you all to engage with early in your research so that you can actually benefit from the community experience. And it does include, as the Latina population in our area increases, it does include not only underrepresented African American populations, but also Hispanic populations.
I think it's one of the areas where community advisory boards can really help. For people who use drugs, that's a little bit challenging in our area because no one really wants to formally put their name on a board as doing something that you can get put in jail for. But what we do use is we use a monthly meeting with our harm outreach coordinators, and they bring us back the voices of those people that they're serving on a regular basis. And for us, that's been really key in making sure that we're asking questions that the community that we want to serve is interested in. So I think that, the type of partnerships that ICTS has allowed us to make, partnering with institutions that do these sort of community outreach events and things like Street Med and UMSL has been really important in making sure that we're actually serving the people that we want to serve.
Can I just add to what Laura just shared? Yeah. I really just want to emphasize the word with again. I mean, like, thinking about working with any marginalized community, whether it's people who inject drugs, whether it's people who are part of Black communities, African American communities, whether it's Latina communities in St. Louis, all of these folks represent marginalized populations in our country. And I don't think it's just a matter of like bringing the latest technology out into the streets and saying, here it is, come get it. I think it's actually a matter of like utilizing different methods, bringing qualitative methods to bear. So ethnography has been a wonderful way for us to learn from people, but also build really strong relationships with people and build probably long-lasting partnerships with people. Human-centered design is a technique that we're using at the CCHPR, which, I mean, it's an excellent way to engage with folks who are on the margins and learn from their experiences, and also acknowledge that, like, inviting them into the system is maybe not the answer, that like a change to the system is probably necessary, and we're only going to be able to identify those changes by engaging with the communities that we're seeking to serve. And so I think that that's like something that we've all highlighted and really would encourage anyone who cares about this to think about.
This is more a comment or an observation, but something that I picked up from both Laura and Brett, and you as well, was that you had to kind of use different methods that maybe you weren't expecting to use. Like, you had to actually go out, you weren't sending out emails, you had to send out physicians to actually meet people in person versus expecting them to send things back. And I think it was just something that I observed in this world we're in, 2024, there's so much going on with AI and technology, and remembering that not everybody has equal access to everything, and kind of keeping that in mind as you're developing trials, as you're thinking about how to move things actually into the communities, is remembering that not everybody has equal access, and how do you approach them, and how do you keep them involved, and even deliver the things in a way that actually makes sense to how people live. And I think that also speaks to what Bill was saying about how not everybody's in these large academic centers. Small rural hospitals are going to have limited resources. And even what you were saying about the medication that your trialist was like, what are we doing this for? Like an IV med versus a pill, like, come on. So it was kind of an observation that I think people always need to kind of keep back of mind when they're trying to do implementation science and when they're trying to incorporate the communities, is that access is not equal.
Another question here.
So I was wondering if you had for de-implementation research, do you find that you have more of an uphill battle of including underrepresented populations? So I participated in your study when I delivered my daughter in 2021, but for me, as a clinical researcher who works here and as a white woman with reasonable trust in the medical system, it was like a no-brainer. But I could see groups who may have more distrust in the medical system, it might be harder to say, yes, I'm okay with you removing care, rather than, okay, I can help advance science, or this care may help me. But here it's like, well, I'm going to remove something, and I promise it's not going to make it worse for you. So have you found that that's been harder to include those groups?
Great question, and thank you for participating. Yes, it is challenging, and especially when it comes to something like oxygen, where the general notion in the public is the more the better, right? Like, you guys have seen those oxygen bars in Vegas where you just like get a cannula and hang out for some time or whatever. So like, people really generally think that oxygen is good for you, which is a fair assumption to make if you don't know much about the risks of hyperoxygenation. So yes, it is challenging to engage patients in that kind of work as much as it is to engage providers in that kind of work. But our research teams, I think, have done a really good job in terms of using patient feedback to craft our informed consent process, to really first understand what the barriers are to participating in research as a whole, then secondarily understanding what the concerns are about oxygen, and sort of building that into the discussions that we have with our patients. And then in terms of sort of speaking to the like underrepresented patients and sort of getting buy-in from them, I would say one important lesson I've learned is that my research staff or my research team have to reflect the population that we're also trying to recruit. And that change in our research operations and the recruitment of diverse research staff has really made a big difference for us. And where we now, among many obstetric centers, are probably one of the centers that recruit the most diverse patients and on labor and delivery. And I think that really speaks to nothing I've done, but really having folks from diverse backgrounds be on our team. So many of you are probably familiar with data that exists that shows that Black patients have better outcomes when Black patients take care of them. And I would venture to guess the same thing moves over to the research space, in that we are more likely to do successful research if we also have diverse representation on the research end.
I'll definitely second that. I'm going to get far less information about how people use drugs if I walk in a white coat than if I send two of our absolutely fabulous team members that are persons with lived experience with drug use histories. They get much more comprehensive and outstanding qualitative interviews than if I waltz in there. And I think it's so important to make sure that your research team reflects the people you serve, because they bring so much more experience to the table.
And I don't have a direct clinical experience like the two of you, but the interviews that we've done on our project, we do a series of 3 interviews with people, and the second one focuses on their past experience with healthcare and medicine. And so we get into a lot of conversations around trust, mistrust, and what we've found is that more isn't necessarily better. So like, the idea of de-implementing may not necessarily be something that gives people pause, but a sense of belonging, which is one of our sort of core values of our work, is important. And so the extent to which people can feel like they belong in the conversation with the person providing care, whether that be through like providing care from a person who looks more like the person that they're sitting across from, or has shared experience with the person that they're sitting across from. But the more that that person feels like they belong there and that they're part of a conversation, I think the easier it's going to be to like lead people in the directions that we might know are best for them.
Nancy.
I just want to take the opportunity to talk about an ICTS initiative being led by Yi Zhang. If you are interested in diversifying your clinical research workforce, we have an apprenticeship program that started working with the Department of Labor and partnering with many of the local, largely community colleges to introduce clinical research as a career opportunity to the students, because many of them have probably never heard of this, putting them through intensive education about being a clinical research coordinator, and then pairing them with units at the university in an apprenticeship model to learn on the job about how to be a clinical research coordinator. So we've got our first class matched and working here actively now. The education is super. We're learning from the first class about how to do it better next time, but there'll be a call that comes out of the ICTS, hopefully twice a year going forward, to give you the opportunity, and this is an opportunity to work with someone, and if you like them, incorporate them into your research group. And they're largely underrepresented minority students who are taking advantage of this opportunity.
And just to add to that, the advantage of doing it as an apprenticeship model is they don't need to have a college degree. They don't need to have, because currently if you go through the WashU HR process to become a clinical research coordinator, you have to have so many educational credits. But if you do it as an apprenticeship model through the Department of Labor, it's like being a carpenter or a plumber. You can come out of high school, you can be trained to do the job, and then you get a certificate at the end of it that says you're fully trained. And the Department of Labor has endorsed this, and I think it's a great way to start getting more. And we're the first place in the country to do this, and we're not publicizing widely yet because we want to show it's successful. We absolutely believe it will be successful, but when we've shown it's successful, we'll disseminate it widely as this is a model that should be thought about, not just for WashU, but for everybody. I'm going to end by asking each of the panelists one question, which is we're an educational institution, and the ICTS invests a lot of time and effort and funding for the education of early career investigators. I'm willing to put a serious bet that none of you started your careers thinking you would be doing what you're doing now. So what were the key issues on the journey, and are there things that you would have liked to have had more training in now that would have helped you along that way? So Laura, I'll start with you.
So I definitely didn't plan on doing this. I came here to do a postdoc in copper with Jeff. Turns out I'm a really bad copper biochemist. But I think that the most important thing and the most important aspect of my education that I'm so grateful to WashU for was that, you know, it gave me the space to change my mind a couple of times. And it gave me the space to try a couple of different things. And, you know, that's what I love about a lot of the different funding opportunities that ICTS puts out, or, you know, these smaller calls, or the just-in-time program where you can try something and then figure out that it doesn't work and you haven't, you know, sunk years of your life into it, and you can find the right fit. And I think that that's a really important part of fellowship and, you know, those early years of your junior faculty instructorship is finding where your niche is, because, you know, some people are really lucky to find that on the first try. But most of us aren't. We take a couple of false starts along the way. And, you know, as far as what I wish I'd gotten more training in, I think that's the beauty of an academic medical center, is that you can pick up the gaps along the way and realize that, oh my gosh, I have never learned about being a clinical trialist. This is the course I'm going to take, or this is the person that I'm going to, attach myself to at the hip and learn some more, important details about. So I'll put that out there.
I got my PhD here in computational and systems biology, so I was trained to believe in algorithms, which I still do, but like I was definitely like a data guy, a data science guy. And then, so to answer your question directly, no, me neither. I didn't expect to be doing this work, but not because like I didn't expect to be doing community engaged work. I didn't expect to be like doing academic work. I actually like quit a postdoc to work in public health in New York City. I spent 2.5 years working in the New York City jail system as a community health worker for kids who were incarcerated, and that's both like the reason why I didn't think I would be back here, but also probably the training that if I hadn't done that, I wish I would have gotten. Like that ended up being probably the best postdoc experience that I could have had, because it gave me direct experience with some of the most marginalized people in our society, and some of the values that I hold came directly from that. At this point, I wish I had more training in human genetics, honestly, because I feel like that's where I'm trying to catch up. Like I'm constantly trying to catch up to like the leading edge of human genetics, so I can be both like the person who knows that stuff, but also the person who can go into the community and talk about it in ways that make sense to someone who maybe hasn't finished 9th or 10th grade. So yeah, human genetics is probably what I need more of at this point.
Yeah, I definitely did not intend or plan on being on the implementation science pathway, I will say. And I would venture to guess that a lot of trialists don't start out thinking that that'll be a part of their careers. But I will say, so when I did the MSCI program here, that I think was my real first introduction to the fact that implementation science even existed, honestly, because it wasn't really a part of my medical school curriculum. It wasn't part of my residency training or fellowship training in any way. So I think the MSCI was helpful for me. But if I could go back in time, if implementation science had been built into some of my first trials, then I don't think I'd be so behind on the de-implementation side for this particular intervention that I was talking to you guys about. And the second that I wish I could do and still consider doing sometimes is an MBA, because I think the sort of business operations approach of getting stakeholder buy-in is very, very important on the implementation science side. So I wish that was a skill set that I had learned formally.
Well, with that, I mean, we could continue this conversation for a long time, but we are time constrained. I want to thank the panelists. I want to thank everybody for, from an audience perspective, for participating and staying with us. These are critical issues. We all want to make clinical research more relevant, as I said in the introduction, more relevant to the patients who we treat on a daily basis, and we want to work closely with you as the next generations of clinical researchers in making this process work. So thank you all very much.